Welcome to my channel. Today we are diving into a topic that is quite literally about the heart. We are talking about congenital heart diseases, or CHD for short.
By understanding the basic physics of pressure gradients and fluid flow across heart shunts, you can dynamically derive exact clinical protocols on demand. Let us start with the first exam prompt. Classify acyanotic congenital heart disease and enumerate cyanotic diseases with decreased pulmonary flow. This flowchart illustrates the optimal approach. The highest scoring exam answers classify congenital heart disease strictly by the direction of the blood shunt. Acyanotic lesions are defined by left to right shunts. In this state, already oxygenated blood from the left side of the heart is inappropriately recycled back into the right side and the lungs. You must differentiate these left to right shunts by their anatomic location. They're either pre-tricuspid, like an atrial septal defect, or post-tricuspid, like a ventricular septal defect or patent ductus arteriosus. This distinction drives the clinical timeline. A post-tricuspid shunt transmits high systemic ventricular pressures directly into the delicate pulmonary circuit, precipitating heart failure at a much earlier age than pre-tricuspid shunts. Moving across the matrix, we address the cyanotic lesions. These are defined by right-to-left shunting, where deoxygenated blood bypasses the lungs and enters the systemic circulation. To answer the specific clause of the exam prompt, we subdivide the cyanotic branch based on the volume of blood successfully reaching the pulmonary circuit. Decreased pulmonary flow dictates that there must be a physical obstruction blocking the path to the lungs. Specifically, this is a right ventricular outflow tract obstruction. The RVOT is the muscular channel guiding blood from the right ventricle into the pulmonary artery. Tetralogy of Fallot and tricuspid atresia are textbook examples. Both feature severe obstructions choking off pulmonary flow, forcing deoxygenated blood into the systemic circulation. Structuring your written answer via this shunt direction and flow volume matrix demonstrates complete pathophysiological mastery to the examiner. Next, we derive the management protocol for a 1-year-old presenting with a large VSD and failure to thrive. This diagram illustrates the baseline pathophysiology. A large VSD creates a massive left-to-right shunt during ventricular contraction. This specific volume of blood diverting into the lungs is called QP, or pulmonary blood flow. Because the left ventricle operates at high pressure, this massive diversion of blood rapidly leads to profound pulmonary overcirculation and subsequent pulmonary edema. That internal pulmonary edema directly causes the external clinical sign of severe tachypnea, which is abnormally rapid and shallow breathing. This explains the failure to thrive mentioned in the prompt. The infant burns massive amounts of calories struggling to breathe through the edema, while simultaneously the systemic circulation is robbed of the necessary cardiac output to grow. From this pathology, we can derive the medical management section of your exam answer, following the 4-pronged approach to congestive cardiac failure. Here we see the management flowchart. Step 1. Reduce systemic and pulmonary fluid overload.
You achieve this with potent diuretics like furosemide to drain the pulmonary edema. Step 2. Reduce afterload using ACE inhibitors. Afterload is the resistance the heart pumps against. By dilating the systemic arteries, you encourage the blood to flow forward to the body rather than backward across the VSD. Step 3. Optimize myocardial contractility to handle the massive volume load, utilizing agents like digoxin or beta blockers such as carvedilol. Step 4. Directly address the failure to thrive prompt. The child requires high-calorie density feeds to overcome the metabolic demands of chronic tachypnea. Once medical management is outlined, transition immediately to the surgical protocols. The primary triggers for surgical closure are congestive cardiac failure presenting early in infancy or continued failure to thrive despite maximal medical therapy. The absolute surgical mandate is the appearance of early signs of irreversible pulmonary arterial hypertension. If pulmonary vessels permanently stiffen, the defect becomes inoperable. Managing a large VSD is a high-stakes holding action. You are chemically balancing pulmonary flooding against systemic starvation until the defect can be surgically closed. We arrive at the final, highest yield exam prompt, the emergency management of a cyanotic spell, or TET spell, in a 2-year-old child. The physiological trigger of a TET spell is a sudden, drastic increase in right-to-left shunting.
Mechanically, this is caused by a violent spasm of the infundibulum, the muscular funnel leading out of the right ventricle, completely choking off pulmonary blood flow. This diagram shows the immediate consequence. Deoxygenated blood hits the blocked pulmonary artery and is forced entirely out the overriding aorta, causing profound systemic cyanosis. The textbook protocol required for your exam answer is a precise checklist for manipulating vascular resistance. We will translate this table into a step-by-step hemodynamic algorithm, beginning with immediate physical positioning. Step 1 is placing the child in the knee-chest position. This specific action physically kinks the femoral arteries in the legs. Kinking the arteries drastically spikes systemic vascular resistance, or SVR. This is the total resistance offered by the systemic circulation. Spiking the SVR creates massive back pressure in the aorta, forcing blood back across the VSD and toward the lungs. Step 2 is the administration of 100% oxygen. The physiological trick here is that oxygen is a potent pulmonary vasodilator. It actively lowers pulmonary vascular resistance, or PVR, widening the vessels to invite blood back into the lungs. Step 3 is administering subcutaneous or intramuscular morphine to sedate the child. Morphine serves a dual mechanism. It stops the crying, which lowers the circulating catecholamine levels driving the muscle spasm, and it actively reduces venous return to the right heart. Step 4 requires administering intravenous fluids to correct underlying hypovolemia. This maximizes the preload, which is the volume of blood stretching the right ventricle, giving it the mechanical force to push past the obstruction. Step 5 of the protocol involves the administration of intravenous beta blockers, specifically metoprolol. Beta blockers can relax that hyperactive infundibular muscle spasm, reopening the right ventricular outflow tract. Step 6 is the administration of sodium bicarbonate as a final measure to correct the severe metabolic acidosis induced by the prolonged tissue hypoxia. Treating a TET spell requires solving a real-time physics problem, balancing systemic and pulmonary resistance through pharmacological and mechanical force. Here we see the 3 completed exam answers. By applying first principles, they are logical, interconnected flowcharts. Acyanotic failure is a problem of excessive volume and pulmonary overcirculation. Cyanotic emergencies are problems of vascular resistance and systemic hypoperfusion. When faced with these scenarios under exam conditions, relying on the physics of the shunt will automatically generate the correct clinical protocols. True clinical mastery and pediatric board certification are built entirely on first principles, rendering rote memorization completely obsolete.